Yep.
Awesome. So, yeah, thanks, Christy, for kicking it off, and thanks to the Triangle team and for Tom for being here. My name is Paul Kulpa. We have worked very closely with Imagine 360 over the last couple of years to develop a new health insurance program for TAC members and ag businesses that are related to TAC. So, what we're going to do is we're going to kind of talk about. I'll kind of give you an overview, introductions. I'll let Tom introduce himself because he does a much better job than I do. We'll talk about the healthcare problem, which I don't think anybody on the call today is probably is a shocker to them. I think we all know what the healthcare problem is, which is everybody getting 10 to 15% premium increases every year, and hopefully we can kind of outline what our solution is and how it affects that, how it changes that. And then Tom will really dig into the details of how this thing works, as Christy mentioned, around the reference-based pricing piece and why it makes this different, and the support that Imagine 360 provides to you as an employer, but also the employees that are on the health insurance program. So who are we? So Agri-Services Agency, we were formed 50 years ago from a milk marketing cooperative in the Northeast United States, and have since grown over the years, covering pretty much all over the country. What we do every day is help agriculture and farmers and ag businesses. We were founded by farmers. We support farmers. We exclusively serve the agriculture community. That's what we do every day. That's why we feel like we have the expertise in what we do. We've been administering health insurance programs for over 50 years. We also have our own workers' compensation program and other things as well. But the point is that, when healthcare reform was passed, I guess it was 15 years ago now, and implemented about 10 years ago, it changed the landscape of the health insurance marketplace. And, we had a lot of programs out there that we couldn't, quite frankly, continue to administer just based on the rules of ACA. So we kind of took a step back about 3 or 4 years ago and said, what can we do, to help the farms and ag businesses in those, quite frankly, what we feel are underserved markets. And when we looked at it, we realized there really wasn't a national solution out there. So we started taking kind of a, one step at a time. And we actually rolled this thing out in Kansas last year, and are looking to, roll this out in Texas with the partnership of Triangle and TAC this year. So, at the end of the day, we feel like this is a differentiator. The point I guess I want to make is we've been doing this kind of stuff for a long time. Imagine 360 has been doing this stuff for a long time. And we've kind of partnered together to kind of develop this new program that we feel is unique and there to help the farms and ag businesses. So with that, I'll kind of hand it off to you, Tom, to kind of introduce yourself and Imagine 360.
Thanks, Paul. Hi, everybody. Again, my name is Tom Pusic. Work for a company called Imagine 360. Used to be called ELAB Services, if you may have heard of that. But we started reference-based pricing a little over 15 years ago, or what's now called reference-based pricing, a little over 15 years ago. And we did it because, we're just trying to help the people that need help out there, the people who either can't afford insurance or can't afford their deductibles, and try to get it as a new way of developing reimbursement and payment to the providers that are out there in a very fair manner to everybody. But it helps with the healthcare increases that are going up, as Paul had said. And so we've been doing this over 15 years. And just to give you a little context, I've been with the company a little over 12 years now. When I started, we had 30 employees and 50 clients. Now we've got over 1,500 employees and over 1,000 clients. So this isn't a new deal. This is very prevalent across the entire country. But I will say we have more clients in Texas than we do anywhere else. We have probably, of the 1,000 plus clients we have, 300 plus are in the Texas, are domiciled in the Texas market. So we've been doing really well there. And then we'll get more into it as this presentation goes on.
Thanks, Tom. So I think everybody knows what the challenges are that you all are dealing with every day, and we're all, quite frankly, dealing with, which is one, comprehensive or access to comprehensive quality health insurance. And you'll probably be sick of me saying it by the end of this presentation, but I like to point out the fact that this is comprehensive health insurance. And I say that just because, what we've seen in this is we've seen 15 to 25% savings against the marketplace of, the Blue Cross Blue Shields and the United Healthcares of the world. And you're going to sit there and say, well, how can you do that if you've got quality or comprehensive health insurance? And Tom will explain that. But the point I want to make is that, these plans cover everything you would expect them to cover on a health insurance policy. Preventive care covered in full, inpatient, outpatient, labs, x-rays, prescription drugs, everything that you would expect to be covered in a group plan is covered in this program. The other thing is the ability to find affordable plans from both a premium and out-of-pocket perspective. And I think we'll hit on this point a few times. But we talk about the premium savings that we're seeing from an employer perspective. Well, quite frankly, the employees that have the plan that are utilizing the services are also going to see lower costs and lower out-of-pocket costs from a deductible and an out-of-pocket maximum perspective. A challenge obviously is access to healthcare providers in rural areas. We feel like, Blue Cross Blue Shield typically has a pretty good network. A lot of the other carriers focus on the metropolitan areas, and they might not focus so much on the rural areas. And our solution, I think, addresses that. Obviously, year over year, as you continue to see 10, 15, 20% increases in your premiums, that you have a limited ability to kind of shift those costs onto the employees, whether that's in premium or in higher out-of-pocket costs. And we understand those challenges, right? And then, finally, I think every group and every employer has, concerns and issues recruiting and retaining quality employees. And, at the end of the day, you've got to offer a benefits package to them. And we feel like this really does help those employers put together a nice package for their employee base. So, those are some of the challenges, and hopefully we feel like we're addressing a lot of those challenges. So at the end of the day, we feel like companies and their employees deserve to pay a fair price for quality healthcare. And that's what we'll talk about as we go through this presentation. And I'll kind of hand these next few slides off to Tom, because a lot of this data came from Imagine 360 and actual data that they have. And he can explain kind of some of the issues that we're dealing with.
Thanks, Paul. And just to reiterate what Paul said a couple slides ago about this being a quality comprehensive health plan, virtually all of our clients, when they move from a typical, Blue Cross Blue Shield or United Healthcare model to our reference-based pricing model, they're always asking us, well, what's our benefit plan got to look like? And our answer is always the same. It can look however you want it to look like. And virtually all of them either keep the exact same comprehensive benefit plan they've got, or in many cases, they'll enhance it by adding some benefits they always wanted to add because they know they're going to save the money, or dropping out of pockets for their members that are out there. So it truly is a comprehensive plan. This slide here just kind of shows how crazy healthcare pricing is today. And in today's world, in the what's called a PPO model, preferred provider organization model, like Blue Cross or United or Cigna or Aetna, the way claims get reimbursed is a discount off of bill charge. And a facility, a hospital will set a bill charge out there, and then Blue Cross or one of these big carriers will come in and negotiate a discount off of that bill charge. Well, they negotiate a 40-50% discount off the bill charge. You're thinking you're getting a good deal, but all the hospital needs to do is just keep on upping and upping the bill charges. And this has been going on for 50 years since networks first came into play, and it just continue. I mean, you can see all these types of markups, and it's not these claims here or claim there or claim. It's every single claim that are hundreds of percent, if not over 1,000% markups over what it's actually costing them to buy a gauze pad or a test strip of diabetes test strip. And so we're trying to change that paradigm of discount off a bill charge. Go ahead, Christy, the next slide. I mean, as Paul also said, I mean, we think that this model doesn't help anybody and is virtually unsustainable out there. I mean, if you would look at workers' earnings versus premiums or deductibles or out-of-pocket costs, there's just a huge gap, and companies just can't afford it anymore. They can't afford healthcare. And in many cases, employees can't afford their deductibles. I was in doing a pitch to a senior living group in Dallas a couple of weeks ago, and the person, the head of HR, was talking about how they've got an employee, they're on their health plan, they've got a really good health plan. She needs to get a procedure done. She couldn't go because she couldn't afford a deductible. I mean, that's crazy if you think about it. You're paying the premiums, you're paying what you have to do, you have your coverage, and you're not going to get your procedures because you can't afford the deductible. And that's what we're trying to solve here. Go ahead, Christy, the next slide. You can see this shows state by state what the markup is above Medicare. Medicare, if you don't know, is kind of like the Kelly Blue Book of healthcare. It's pretty close to what it's actually costing hospitals to render services, and sometimes costs a little bit more. Sometimes Medicare is a little bit more, but it's virtually about the same. Virtually every hospital accepts Medicare payment and accepts Medicare patients into their facilities. Yet you can see what their bill charge markups are here. In Dallas, the average markup is 1,000%, almost 1,000% above Medicare. Again, it's just unsustainable. And these numbers keep on going up and up every year as they keep on raising their bill charges every year. Go ahead, Paul.
Thanks, Tom. So I'll just kind of go through the next few slides and then to kind of give you an overview of the actual AgriCare health plan and some of the guidelines around it. And then I'll kick it back to Tom to kind of really get into the details of a lot of what he was just alluding to as it relates to reference-based pricing and really the member support that goes with it. So just a couple of quick things. So again, we launched this new health insurance program it is considered an association health plan. And what makes that unique is that, an association health plan is essentially built for like businesses. So agriculture, for example, and that's kind of what we're doing. So, all eligible participants are farms, ranches, cooperatives and other ag businesses that are related. And then, I mentioned we did our initial launch in Kansas and are launching in Texas in June. The benefits of an association health plan, it really offers the opportunity for an employer group to optimize their health insurance program and really allows small groups to sort of like share in the benefit of a large group plan. And to explain that a little bit, if you've got a large employer group of, let's say, 5,000 employees, they have a lot more options, to look at, whether it's on a self-insured basis, and looking at, incorporating wellness programs to kind of keep claims costs down and those sorts of things. Well, small groups, typically a group of 5, 10, 15, they're just going to get their, 12, 15% increase from Blue Cross every year, and there's nothing they can do about it. They have no control over it. What this does is it allows a small group to buy into a large employer group plan and see the benefits of that plan, and really have a little bit of skin in the game with that. So that's what kind of makes an association health plan unique. And that's why we thought that this would be a good solution, for the TACC membership. I'm not going to read this eye chart because you probably can't see it anyway, but the point of it is that there are a number of different health plan options available. We looked at the marketplace, and we didn't copy the market as far as what's out there, but we said, what are the typical deductible levels and out-of-pocket maximum levels that people are seeing, particularly in the small and medium-sized group markets. And we kind of looked at those and provided a number of options ranging from a $750 deductible, which is a pretty low deductible in the marketplace nowadays. That's a little bit of a richer plan, all the way up to an $85.50 deductible. So we understand that every employer, every farm, every ag business has their own specific needs and wants. And some folks might want to offer a rich plan to their employees at a higher cost, and some may say, what, I just want to offer something because God forbid if something happened, I've got catastrophic coverage. So the point is we've got a number of deductible levels. We've got PPO options. We've got HSA qualified high deductible plans that folks can open health savings accounts with. So there's a wide range of options for folks. Just a high level, some of the guidelines. Every program, every health insurance carrier has underwriting guidelines, and these are just some of the some of the high level ones from our perspective. Obviously, you must be a farmer ag business to be in this program. We can actually write sole proprietors in any size group, two or more. And we have a 60% participation in the program, which means if you have 10 employees, you have to have at least 6 sign up for the program after valid waivers. And what valid waivers are, you might have an employee that is on their spouse's coverage. They might have Medicare, Medicaid. There's a number of different valid waivers that are considered that wouldn't go against your participation levels for the program. And then the other thing is the great thing about this, quite honestly, is that it is an underwritten program. It's a medically underwritten program, which means we do look at the risk of all the groups and to come up with the premium rates for the program. Now, I will say right at the onset that for the June 1 launch, we're actually waiving those underwriting guidelines. So that's kind of a benefit for we'll call them the charter members that come onto the program. But after June 1st, we will underwrite the program. And essentially what that does is it protects all of you that are in the program going forward. Because we're going to look at every single employer and what the risk profile is for that group. And for the most part, if a large employer can actually get their claims data from carriers, and we can utilize that to come up with premiums. And in other circumstances, we might have medical questionnaires for the employees to complete. The one thing I will mention is that the renewal, we do have a common renewal date of January 1. Which means that every January 1, it'll start over. We'll look at the rates, the deductibles and out-of-pockets will reset and all that kind of stuff. But for the June 1 groups and anybody who comes on during the year, we'll actually apply deductible credits so they're not starting over on June 1st and then again on January 1st. And then the last thing I'll mention is that there aren't management carve-outs, and I bring that up just because we see that a lot in certain ag businesses where they might have 20 employees, but they just the owner wants to have the insurance and maybe a key manager or two. We can't do management carve-outs on that. So we have to kind of meet that 60% participation after valid waivers guideline. And then, lastly, we feel like, better healthcare solution for our members, lower payroll contributions from a premium perspective, comprehensive benefits. Again, I told you get sick of me saying it, but I'll keep saying it. It's a comprehensive program, which will hopefully help, recruitment and retention. Tom will talk a little bit about the open access to providers. You can essentially go anywhere you want from a provider perspective. And then all the support that Imagine 360 provides to the person throughout the entire, process, whether that's pre-service, if someone needs help trying to find a provider, or whether that's post-service and they have questions about their EOB or their claims or anything like that. Imagine 360 is there to help them. And again, I won't steal Tom's thunder because he'll get into some of that. But essentially what we've been seeing, and this is real, we're not making these numbers up. This is actually real. And our head of underwriting is on the call. But we've been seeing 15 to 25% savings against the marketplace plans. And I say marketplace, what you would typically find in the group market. If you as an employer were going out to Blue Cross or going out to United Healthcare to find a group plan for your employees, we're seeing 15 to 25% savings against those plans. And that, again, that's very real. And then I'll kick it back to Tom, but I think I just absolutely love this slide because it goes to what Tom was describing earlier as far as how the current market works and how reference-based pricing is different and how it really does save that money. So with that, Tom, I'll kind of kick it back to you.
Thanks, Paul. If you didn't get it from what I was talking about before, I mean, this whole concept of reimbursing claims at a discount off of a bill charge, where that bill charge keeps on going up and up and up every year, is just it's just crazy, and it's really nobody's fault. It's just the way preferred provider organizations came into play when networks came into play 50 years ago. It was a great concept at the time. It was made to steer people to certain facilities that would give you a better discount. And so that made sense. But when you go into a Blue Cross marketing plan today, they're boasting about how 99% of the hospitals are inside the network. Well, that defeated the whole purpose of a preferred provider to begin with. And now you're just paying for those networks, and when everybody's inside the network, and it's just gotten crazier because prices keep on creeping up every year and discounts creep up, but the prices keep on going up. And so under our model, we're basically doing what the rest of all the other industries do in a market society, is that we're determining what's it actually costing that provider to render services, and then pay a markup on top of that. And our solution, we look at two different benchmarks. We look at both Medicare, the Kelley Blue Book, and we look at cost and what it's actually costing them to render that service. So we have a certified Medicare repricer engine. You put in the claim, out pops what Medicare is going to pay. And then we go line by line on every claim that says, here's what it's costing that hospital to render that service, because every hospital has to send in that information to the Center of Medicare and Medicaid Services every year to the federal government that says, here's what it costs to replace a hip or to run a routine CAT scan or whatever it happens to be. And that's all publicly available information. You just have to pay for it and access it and understand it, which we do. We go line by line on every one of our claims. On the hospital side, it says, here's what it's costing them to render that service. So we have those two benchmarks of cost of Medicare, and then just for grins, the methodology is we add 12% on top of cost, we add 20% on top of Medicare, and we take whatever's higher. So we never go below those two floors, but because we're always picking one over the other, the average goes higher than those two floors. We're averaging, if you would look at our 4 or 5 million claims we've processed in our 15 years, we're averaging about cost plus 30%, Medicare plus 40%. So hospitals are getting, on average, a 30% profit margin because their costs includes paving their sidewalks and their cafeteria, along with all their other hospital goods and services. So we're giving them a 30% profit margin, which virtually every one of our clients would love to have that type of profit margin, or 40% above Medicare, which is the Kelley Blue Book, which again, we believe, and it's been proven, that it's a very fair, reasonable reimbursement by using both of those benchmarks. Go ahead, Christy. Go ahead through the next one. Because this is different, healthcare has been pretty much, members and employees have been taken care of by employers for, pretty much ever. A lot of employees are on an employer health plan. Our program's a little bit different. So we knew going in, and our two co-founders of our company are two of my best friends now. We talk all the time, and we knew that the only way we could make this work is to provide outstanding client services to our employers and member services to the employees. And so we've built a model, and it's been beat into everybody's head of our 1,500 plus employees, to make sure that we are taking care of that member. We're not, it's hard to get a live person on the line for one of these big carriers that are out there. That's not us. I mean, we want to make sure that we're talking to the member. We want to make sure they understand. We try to go to as many enrollment meetings as we can, always sending out flyers and reminders about what our program is. And so it's really important for us to be able to have a good touch point with the members that are out there, using what we call concierge services to the member, apps to be able to get to the right provider and the right physician, to make sure that they can get, and as Paul said before, go wherever they want, anytime they want. I mean, one of our mottos is to, every one of our members needs to be able to see the healthcare provider they want to see at the time they need healthcare. And so that's very important to us. I get an email, everybody in the company gets an email every Wednesday that lists out a bunch of quotes from members from the previous 5 working days. And we a lot of times we'll put those in LinkedIn or wherever, but just things that our members are saying about the services that we'd be able to provide. Every time somebody has a question or an issue or whatever, and they contact our member services, we send out a survey to them about how did we do. We have a 98 positive member satisfaction rate from our members. And then what we're told, and it's all done by a third party, And what we're told by the third party, even more impressive than 98%, is we get a 40% response rate back. And a lot of people just don't, you get surveys and you just ignore them, but we're getting a lot of them back, 40% of it. So we're really proud of what we're able to do there. Good. The next slide. We provide, which we think is really important in today's day and age, is telemedicine. A lot of times it's hard for people to get to their primary, or they don't have a primary care physician. We work with a company called Recuro Health, which is a virtual primary care physician that does behavioral health and primary care 24/7. They'll write scripts, they'll do that. It's very important in this day and age, and people are getting more and more wanting to not go to the physicians. And so we think it's very important to have a really good virtual program in place as well. Go to the next one. So essentially it works exactly like it does today. And we were removing that whole network component as it relates to hospitals and inpatient, outpatient, some of the surgical centers that are out there, inpatient, outpatient type of procedure. If it's a physician, we do have a reference-based pricing program, but we also have networks, especially down in Texas, where we have a lot of clients down there. So we'll take a look at that. But for the most part, we're removing the network as it relates to hospitals and surgical centers that are out there. But it works exactly the same way. You'll just go in, you'll be admitted into the hospital, you'll get your procedure done, and a claim will be cut to the third-party administrator, which we are a third-party administrator, and we'll pay the claim based off of cost plus or Medicare plus, as opposed to a discount off the bill charge. Now, this is time and place, and you can go to the next slide, Christy, where a lot of times I'll get the question of, we'll get a routine CAT scan in. Let's just take something relatively simple. A lot of times the bill charges will be around $5,000. It costs the hospital about $150 to do a routine CAT scan. And so, under a carrier model, if you get a 50% discount, you're going to pay $2,500 for that CAT scan. Under our model, we're going to pay cost plus or Medicare plus. We're going to pay about $300 or somewhere around there for that very same procedure, that very same CAT scan. And what can happen on this is, so a hospital bills $5,000. If they thought it was Blue Cross, they get $2,500. Under our models, they get $300. So I get a lot of questions says, why would a hospital accept that? And the answer is they don't have to. They can actually balance bill you as an employee that says, you're not part of a network. We don't have a contract with you. I billed you $5,000. You gave me $300. Where's the rest of my money? And that's within their rights to be able to do that. And we welcome them if that's what they do. The reality is when we first started reference-based pricing, the balance bill rate on those types of claims was about 18 to 20% when I started. Today, it's about 3.5 to 4%, because as we're getting more prevalent out in the marketplace, hospitals are realizing they're getting a fair reimbursement above their cost, above Medicare. They're happy with that. It still happens, though. 3.5, 4% of the time where they're going to balance bill. And so the key to this program is if you get a balance bill, or even if you're getting ready to be admitted in the hospital and they look at your card and it says Imagine 360 logo as opposed to a Blue Cross logo, maybe they have questions about coverage or what their copay is or whatever. The key to this entire program that we constantly tell employees and employers, flip over that ID card and call the number on the back of that ID card. That's how we get this program to work. If a balance bill occurs, sometimes EOBs get confusing. Sometimes people don't know the difference between an EOB or a balance bill. Flip over that ID card and call the number, because we won't know if a hospital is balance billing. And the only way we know is if we're being told by the employer. Now, sometimes they'll tell their employer or whatever, but as long as everybody knows that, we need to get involved, because we will take over that balance bill. In the history of our program, we've never had an employee that's paid an extra nickel outside of their out-of-pockets, as long as they follow the process. And that process is flipping over that ID card and calling the number on the back so we can take care of that balance bill. And in many cases, they'll accept are once we explain to them what reference-based pricing is, how they're getting a fair, reasonable profit margin, a lot of times they'll accept it. Sometimes we'll have to negotiate that as well, which we're able to do. We've realized over 15 years, if we win 96, 97% of the time, and we have to negotiate 2 or 3% of the time, that's pretty fair. That's a decent deal, and that's all built into the 15 to 25% savings that Paul alluded to before. Go to the next slide. So this kind of just went through the whole thing, but basically the payments are get accepted where there are times when you have to flip over that ID card and call that number is A, if you get a bounce bill, or B, if the provider at time of admittance doesn't recognize that logo on the ID card and they have more questions. And so sometimes, we'll make the appointments for you if you want us to do that, or we'll talk to the provider. But again, the whole idea is to get on the phone and talk to us so that we can work with the provider to make sure A, you get admitted, B, we take care of that balance bill. That's kind of the presentation. Hopefully that was pretty comprehensive. I'd kind of summarize by saying, because this works, we're saving people money only because we're saving the members that are out there. We have a 90% retention rate of our clients that are there, which is really, really good. A lot of that 10% are acquisitions or bankruptcies, whatever. We save our clients a lot of money, but we keep our clients because we're taking care of their employees and the members that are out there. Okay, that's it for me. Any questions? I couldn't have been that good. There got to be some questions.
You always are, Tom.
And one thing that we'll add is the balanced billing situation. It is nice to know that Imagine 360 has a dedicated staff to step in and help answer those questions and take care of a balanced bill. That way it takes the weight off of not only the employee, but possibly the bookkeeper or the manager that may be asked these questions because it's their healthcare program and free their time up from having to try to help with these situations. Not that they wouldn't want to, I'm just saying that Imagine 360 steps in and becomes a partner in that process.
Yeah, thanks for that, Bryce. I would say whether it's a balance bill that occurs 3.5% to 4% of the time, or if it's a question at admittance, which happens, quite frankly, less than 1% of the time with physicians, it's important to us to have a process, no matter what. Even when it's that small, it's because it's that one person, or it's that one claim, or it's that one, we don't want rumors spreading all over companies to say, oh, that we had this issue and nothing, we couldn't get anybody to handle it. We have a process with the 1% of the times that it happens, or the 98% of the time that it happens.
And Tom, it was mentioned in our previous teams that we had, or Zoom that we had, that Matt was involved in, that you guys will even work, once you're aware of a claim, work with the account specifically mentioning, hey, don't forget so and so had a claim. Might check in to see if everything's going well. How's that process work?
We try to. That's a great point, Bryce. So we have a lot of data, and so we utilize a lot of data. We utilize data to be able to negotiate, because we recognize, working with all these hospitals across the entire country, we know when specific hospitals are willing to negotiate, how much they're willing to negotiate before that claim would go to a collection agency or whatever. So we utilize claims whenever on that 3.5%, 4% of the time. We're always trying to get maximum savings if we can. So we utilize data to do that. We also utilize data that says, it happens 3.5%, 4% of the time. Some hospitals that means some hospitals are a little bit more than that 4%. So, and sometimes it's based on the bill charge amount, or how much they're not getting or getting. So we're going to utilize that data as we talk with our clients virtually, all the time, to say, hey, this person, we noticed that this person went to this hospital. They've got a little bit higher bill rate. It's for a pretty big number. We haven't heard from them as it relates to a bounce bill. We know we paid the claim, a week ago, 30 days ago, whenever, but we want to make sure that the client is aware and the employer is aware that that's a potential bounce bill situation. And let's make sure that we're communicating with that employee so that they understand that are they opening? Because, we have a big program that basically says, open up your mail, because not everybody does. And so, people travel, or we have a lot of truckers. We have a program that tells people, please open up your mail, because if a balance bill does occur, we're not going to know unless they tell us. So, but there are specific situations when we know it's a little bit more of a percentage that they'll bounce bill than not. And so we'll remind employers to go talk to their employees. Hey, if you had that big procedure, glad everything's okay. Are you opening up your mail? And a lot of times they are, but sometimes they're not.
I have a question.
Yes.
Do you find statistically how many of the bills will be balance billed?
3.5 to 4% on the hospital surgical center side.
And so then at that point, it's up to the person to make sure that they contact and send this bill to.
That's right.
Imagine.
That's right.
Okay.
That's right. It's unfortunately, there's no other way for us to know, because they're balancing bill the employee, and their business is with the employee, not us as Imagine 360. So we're not able to exactly know if they got a balance bill or not. So we do put a little bit more, accountability on the employees to be able to open up their mail and let us know if the balance. But once that occurs, call that number. And the only thing we're really going to ask, sometimes our members at that point, once they call that number and we assign them a member advocate to handle that balance bill, sometimes people just want to be kept up to date. Sometimes they want to be texted. Sometimes they want to be called once a week, once a month, whatever it happens to be. We'll figure that out with that member at that time. Some people don't want to be disturbed at all, which is fine. I mean, however they want us to deal, that member wants us to deal with them, we will take that over. The only thing we will ask that member is to continue to open up your mail and let us know if they've received anything else from the hospital.
Tom,
Yes.
just to kind of add to that, as a manager, if I was in charge of making the decision on what healthcare plan to go with, and I chose this, I would obviously have a little concern that maybe my employees are not opening the mail.
Correct.
Can you explain how your member advocates work with the member if they had not been opening their mail and now they're receiving collection notices?
So, and this is somewhat of a legal term, but we're a co-fiduciary with every one of our clients. So we are legally obligated to protect our clients, to protect their financial aspects from a co-fiduciary standpoint, just like the health plan is. And so even if you don't open up your mail, or even if you as an employee left your employer, or even if that employer left us because they didn't want to deal with this program anymore, as long as that claim happens during our jurisdiction, so to speak, if that claim happens when they are a client of ours and that member is an employee of that employer, it's our responsibility to take care of that claim, just like we would if you told us on day one. Now, we're going to tell you it's just easier to deal with if you deal with it up front by opening up your mail. But if you don't, and you find out 6 months later, you forgot that to open up your mail and you're just finding it, or they've sent you 6 letters, but we still take it in the exact same approach, the exact same manner that we would if you did it the first day you open up your mail. We just would rather know right away. It's easier for our relationship with the hospitals too. Cash flow is important to the hospital, so we want to make sure that we handle this as quickly and efficiently as we can. But if you don't, we still will handle it.
And you have a dedicated bilingual service team, right?
We have a Spanish speaking, English speaking. There may be a couple more, but we also work with a translation company on Last I heard was like over 80 different languages. So yes, absolutely. And our flyers that we send out are also English and Spanish speaking, and we can get those virtually in any language that people want to get them in.
So, Chuck, real quick, I used to manage a cooperative, and my guys are obviously not making a lot of money, but let's just say they had a pretty serious procedure, and you guys going to negotiate this, and the hospital says we're not giving. Does that happen? I mean, could I have an employee that could possibly have a $20,000 bill if they just want to be contrary?
So just to be precise, they could absolutely have a $10,000 or $20,000 bill, but the reality is, as long as they call us, they're not going to pay anything outside of their out of pockets, meaning their copay, co-insurance, deductible. I mean, so we've never had anybody in 5 million claims that's paid any more than their out of pockets. That doesn't mean they're not going to get a bill. I mean, they very well could get a bill. We just need to know if they get a bill so that they contact us.
Okay.
And we provide any legal support. It's all part of the program. If we need to have our attorneys kind of come in and deal with the hospital on a legal standpoint, if it does happen to go to collections, one of the reasons why we want to know right away is so claims don't go to collections. We would want to know about it. We will never close a claim out if we know they're in collections until we get that reversed. And if their credit got impaired, which rarely happens in a lot of places, is illegal now. But yeah, they very well could get a bill, but that's what you do when you get a bill is you call us so we can take care of it.
Okay. I just know the panic that can happen when you get a bill like that. And with our guys, a lot of times, again, you guys touched on the fact that you've got Spanish speakers and things like that, which is awesome. But I just, that just kind of dawned on me. I'm like, man, they're going to freak out if they get a huge bill from the hospital and then, it goes sideways. But gotcha. Thank you, sir.
No, and I really, really appreciate the question because it's a great question. It's on everybody's mind that they will. I would ask them. In some ways, people are freaking out now just because their premiums go up every year and their deductibles go up every year, and so we're trying to stem that tide to have somebody in there, fighting for them and be there for them, being an advocate for them. A lot of them appreciate, but I appreciate that there's people out there too that get, the healthcare has been going the same way for 50 years now, and we are trying to change the tide of that. And so that does make people anxious, so to speak. And we know that. And so we work with those people virtually every day to help them understand, to help them that we're there to, so that their pocketbook doesn't get lower. Any other? This is great. Love the back and forth.
Are the producers that are members of cooperatives, are they, from my reading, it seems like that they would be eligible for this. Is that right? If they are members of the cooperative and the cooperative is a member of TACC, is that right, Christy?
That is correct. We are asking them to become a Producer Health Alliance member. We create a whole membership level specifically for producers.
Okay.
We asked them to do that in addition to, because we didn't want to connect their ability to have healthcare to their TACC membership, just in case something happened and their co-op merged or they didn't, keep their membership, their co-op. We want it to be independent.
Okay. Good. I can see this as being beneficial. This is something that, rural families talk about often. And as we know, costs of everything have gone up substantially. So if there's an area where we could maybe push pause on costs going up, even if just a little bit, would be really helpful to these, farm families and these rural communities where we live.
Absolutely. And our goal is to build the biggest group as possible. So if we can build a big group, that means cheaper premiums for all.
Right.
And I don't know if this makes you feel better or not, but we're on the same plan that I've just been talking about. It's Imagine 360. I live in Omaha, Nebraska, and I'm on that plan. And there's one hospital here that's known to bounce bill a little bit more than others. I went there just because of that, because I kind of wanted to see what would happen. And I didn't get a bounce bill, but I mean, sometimes we like to test the system to make sure it's working, but it's working for all of us as well as all of our 1,000+ clients.
And Tom alluded to it earlier. I mean, they were born in Texas and they've got a lot of business in Texas and they've been doing it a long time in Texas, which I think says a lot.
Yeah. Great, Christy. We'll send out my contact information.
Yep.
Anybody, anytime can email me or call me if they've just got questions they just want to ask, if they're just curious about something, if they want to know how their hospital in their hometown does with our program, we can give you stats on that. So anything that you want at all, we're willing to help with.
We've actually seen some of those stats and I was very impressed with them. So if you need stats, they can get them.
We get a lot of data.
All right. Well, thank you all for joining us. As Tom said, we'll get all the contact information out to all of you. And then, of course, Jana Haggard is our main contact with Triangle, and she can help you as well. And just a reminder, all quotes are free. So if if you want to know where you'll come in, Jana's happy to help you.
Quotes are free and questions are free.
That's right. All right. Well, thank you, everyone. We're going to end today. And again, if you have any questions, just keep in touch.
Thank you.